Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman, for the introduction. I'd like to thank the organizing committee for the kind invitation and make me part of this meeting. Today we will talk about completing the session in the RCC. We are talking on urothelial carcinoma, especially it's transitional cell carcinoma, maybe mostly the bladder, the renal pelvis, and ureter, and sometimes the urethra. Here are my disclosures, and this is the agenda. We will talk about some introduction about immunotherapy in urothelial carcinoma and why the rationale behind this, and what about the first line of immunotherapy, and is there any role for maintenance treatment? Is there any role for immunotherapy in second line? And later on, the evolving role of immunotherapy as adjuvant in urothelial carcinoma, as well as Professor Ahmad said in the RCC. All of us know that transitional cell carcinoma without treatment, the advanced or metastatic disease, have very poor outcome and short survival, just doesn't exceed 6 months. And the backbone of treatment for those patients are the systemic treatment and the median overall survival with the most effective treatment just reach 15 months. This is the best situation we have with the chemotherapy. The backbone of the systemic treatment before was the chemotherapy and the cisplatin-based chemotherapy, mainly the gemcitabine cisplatin and the MVAC regimen, which is famous for us. This is for the patient who are cisplatin eligible. I mean the fit patients who has a good performance status and good renal function. But unfortunately, we couldn't have this patient in our daily practice. Why? As you know, as mentioned by Bajorin et al., we have in the first line, we can classify patient not only based on that the patient has advanced or metastatic urothelial carcinoma, but there is other factors which may affect the patient outcome, like the performance status and the presence or absence of visceral metastasis. If the patient is good, you expect a good benefit from the systemic treatment. Maybe the median overall survival reach up to 3 years. But if we have two factors, this survival decrease up to 9 months with the best regimen you have, and if you have only one risk factor, even the survival may reach up to 13 months. Also, the cisplatin is not an innocent drug. There's a lot of complications. It's a very difficult drug. Yes, we are familiar with dealing with the complication of cisplatin, but it's still a very difficult drug. Also, remember that not all the patients with urothelial carcinoma are fit for cisplatin because we have renal complication because of the disease. This is lead to the criteria for cisplatin eligibility, and there is a lot of definition for this. Most of these are related to the creatinine clearance and some both the performance status and the toxicity expected from the drug. So whatever the criteria you use, there is some limitation when using cisplatin. So patients are classified into cisplatin eligible and cisplatin ineligible drugs. About 50% of the patient will be cisplatin ineligible. For those patients, as we expected, we couldn't give cisplatin, and we have substituted this by other agents like carboplatin-based regimen, and we expected that with this regimen, we expect inferior outcome rather than cisplatin. As you see here, the median overall survival for the fit patient for carboplatin, not cisplatin, just 9 months. So we have a lot of unmet needs in patients with bladder and other urothelial carcinoma. Why? Because most of the patients present with this disease are older age with a lot of comorbidities, and also the backbone for those patients is platinum-based regimen, and most of these patients, if the patient has bad performance status or have visceral metastasis, we expected poor outcome as mentioned before, and patients who did not receive the chemotherapy already did badly than patients who received chemotherapy. So, and as mentioned before, there is 50% of patients will be cisplatin ineligible. The alternative is carboplatin and other regimen with expected poor outcomes. So we are faced with area of unmet needs for the patient who will present with us with urothelial carcinoma. Is there any alternative for those patients? What about immunotherapy, which may be attractive in this area? is there any rationale for using immunotherapy for such patient? We remembered from using BCG, which is type of immunotherapy in bladder cancer, that may be a role for the immunotherapy in this disease, but unfortunately BCG was restricted to patients with non-muscle invasive bladder cancer and did not go through further for metastatic or muscle invasive disease. It has no role. But on the other way, we learned that the high mutation burden are present also. Bladder cancer was ranked as one of the diseases with high mutation burden. So this gives a rationale for why not to test immunotherapy for such population. So is there any role for immunotherapy as first line? We have a lot of agents, as mentioned before. We have Pembro and Atezo. We have also Durva, and we have Avelumab. So we can use these agents as single agent or in combination. Where is the data here? We start with the Pembro for the Keynote 052 for cisplatin ineligible patients. This is a phase 2 trial who are not fit to receive chemotherapy, are randomized to receive pembrolizumab. The primary endpoint for this trial was overall response, while the secondary endpoint was overall survival and safety of the drug, and they stratify patient either BDL positive or negative. Is there any patient who may benefit more based on BDL? As you see for this trial, they included patients with very high risk, as here more than almost half of the patient more than 75 years old and have the same 40% have bad performance status, and also as you look here, 80% of the patient has visible metastasis. If both those patients on the Bajorin model before, we will expect very inferior outcome with chemotherapy. What about the primary endpoint? As you see here in the old patient, we just face a very promising result. So the overall response reached in this high-risk population and this bad outcome population with chemotherapy. When stratified those patients based on the BDL, the overall response reached in the BDL less than 20%, but it doubled with BDL more than 10%, reach up to 50% overall response. This is a very attractive results with these agents. When we go for the subgroup analysis, as you see here, as mentioned before, the BDL1 positive have highest response rate. Also, the performance status doesn't matter, but patient, especially with lymph node metastasis, has better outcome, and this is expected from immunotherapy than patient with visceral metastasis, but still patient with visceral metastasis still have benefit from this. And in the sector of patients who are BDL1 positive, still there is benefit in the lymph node positive patients. And as you see here, the median overall response, remember that with carbon, we just reach 9 months, but with this, we reach up to 13 months. But when we stratify patient based on BDL1, the patient with BDL positive, the median overall response reach up to 18.5 months. This is very promising, more than the expected from the cisplatin as mentioned before. So this lead to approval of Pembro in platinum ineligible patient as first line. What about other agents? These, the InVigor 210 trial, which phase 2 trial, just 2 cohort. To the first cohort for patient with cisplatin ineligible, just they give them the atezolizumab, and they classify patient or stratify those patients based on also the BDL. As you see here, the primary endpoint was overall response also. As you see here, maybe have the same results with patient with Pembro 20-something in the overall response in the whole population, but strange enough here that you find that no difference based on the BDL status. All the patients did the same. Here there is more improvement than Pembro for overall response here, overall survival, that for the first time also in cisplatin ineligible patient, we found with atezolizumab that the median overall survival reached up to 16 months. This led to the approval of this drug in patient with cisplatin ineligible as first line. So we have now two approvals, the pembro and atezolizumab. What about durva? Durva was already addressed regarding single agent or based or added to tremelimumab, which is CDL4 inhibitor, compared to care, which is cisplatin based. Here in patients who are fit for cisplatin, is there any superiority for either monotherapy or combined for this agent compared with chemotherapy? Here, yes, there is some numerical improvement, but unfortunately did not reach to statistical significant. Whatever the patient, either durva single agent or durva combined with tremelimumab. Yes, there is some improvement, but did not reach statistically significant. This led to decline, and durva was removed from the first line in metastatic or locally advanced transitional cell carcinoma. So this is for the single agent immunotherapy or combined immunotherapy. What about, this is give a rationale. Why not to combine immunotherapy plus chemotherapy in fit patient to have to maximize the benefit in the first line, but in cisplatin eligible patient? And they tested two agents, the pembro and also the atezo. Here the pembro plus the standard of care compared to pembro alone or the standard of care chemotherapy. Is there any superiority for the combination? As you see here, just minor superiority did not reach the significant, and either the patient is PD-L1 negative or the PD-L1 positive. So the combination in cisplatin eligible was removed from the recommendations. Again, and the same design, atezo plus the chemotherapy or atezo alone compared with the standard of care. Yes, there is some superiority also, but unfortunately did not reach significant, not that attractive to change our practice in cisplatin eligible, and now we are sticking to the chemotherapy, the cisplatin based regimen as first line. But there is some superiority here for patient with PD-L1 positivity, but unfortunately is not that attractive. So in first line, we just, in cisplatin eligible, we stick to chemotherapy cisplatin based regimen, and cisplatin ineligible we may give carbo or may give immunotherapy as monotherapy. As well here, this combination did not significantly affect the overall response. Also, enfortumab, which is approved as third line, very active agents in bladder cancer, they think about why not to put this agent so early plus immunotherapy, so two promising agent and cisplatin eligible patients. And this is a phase 2 trial, just a rationale or just to test this combination. They found a promising result. The objective response rate about 70% in the first line, with the CR reach up to 16%, and the overall survival reach up to 26. This is maybe promising and attractive, and I think they will shift to a phase 3 trial to test this combination. And as you see here, there is promising and very attractive overall response. We are still waiting about the long-term efficacy, and is there any further phase 3 trial? I don't know up to now they pushed it in the phase 3 trial or not. So this is the first line. Is there any role to maintain any response gained by chemotherapy with immunotherapy? Here is the Javelin bladder trial, which is assessed patient who already received first line 4 to 6 cycles with cisplatin based treatment and achieved at least any response or at least stable disease, randomized just to put the patient under follow-up or to give avelumab as maintenance. As you see here, there is, yes, it is positive results. There is significant improvement in progression-free survival as well as in overall survival, and the benefit or more benefit come for patient with PD-L1 positive. So my first take-home message regarding the first line and maintenance that yes, cisplatin-based chemotherapy are the standard of care and cisplatin patients with locally advanced or metastatic disease, but the problem about 50% of patients are cisplatin ineligible. They have alternative like carboplatin, but yes, there is role of anti-BDL1 and BD1. We have two now. The combination, the pembro and atezolizumab was showing a promising results, and we can give this are recommended for the first line. The combination of chemotherapy plus immunotherapy as first line in platinum eligible patients are not promising. Also, the new combination of IO with enfortumab as first line is promising and need further studies. Lastly, the maintenance IO using avelumab showing significant improvement in progression-free and overall survival, especially in patients with BDL1 positivity. What about second line? Because most of the patients already received platinum-based regimen and already go for second line. The active agents as second line, as you see here, there is comparable results compared with supportive care. There is a lot of trial try to test the immunotherapy, the Durva, showing some promising results. Atezo as phase 3 trial was negative trial, Nivo 2 trial, and Pembro phase 3. We will focus on the last two. Here the checkmate assessed the Nivo as single agent phase 2 trial after platinum failure or progression of platinum in a phase 2 trial. Median overall survival reach up to 8.6, more than the chemotherapy. So this lead to the approval of Nivo as second line after platinum progression, and the benefit was more DL1 positivity. The second agent is Pembro, tested in a phase 3 trial after platinum failure. The Pembro standard of care at that time, which may be docetaxel or venflunine. As you see here, there is superiority of pembrolizumab compared to standard chemotherapy. As you see, there is the median overall survival reach up to 10 months more superior than the chemotherapy, as well the overall response. The benefit are not restricted to the patient either BDL1 positive or negative in the second line. In the first line, there is more benefit in the BDL1 positivity. Also, either the patient received cisplatin or carboplatin in the first line, so he will benefit what he already received. And here the overall response, as you see, and the progression-free survival. This lead to the approval of Pembro and nivolumab as second line, irrespective of the BDL1 status. Is there any role for this active agent to push this agent early? There is a lot of trial in the neoadjuvant now, and also adjuvant. The mature results are with the adjuvant at checkmate 274 for underwent cystectomy for who already received or not received neoadjuvant chemotherapy. For patients who already received neoadjuvant chemotherapy and did not show a promising result, like have T2 and 0, or patient who already did not receive any adjuvant or neoadjuvant treatment, but with high risk criteria like T3 and T4, they are randomized just to put the patient. We know that there is no role or no attractive role of adjuvant chemotherapy in bladder cancer. So those patients are randomized to Nivo versus supportive care because we have no standard of care. And as you see here, there is significant improvement regarding the disease-free survival. We are waiting for the survival, and the benefit more with BDL1 positive more than 1%. So my final take-home message regarding immunotherapy in the bladder cancer or the transitional cell carcinoma, the long-term benefit of chemotherapy as second line, yes, it was promising before, but now for the new agent is limited. Nivo showed activity in the second line phase 2 trial, but we need phase 3 trial to confirm this. Showed consistent activity in the first and second line, especially in patients with BDL1 positive. Recently, adjuvant nivo in high-risk patient after radical cystectomy showed significant improvement regarding disease-free. We are waiting the results of overall survival. Yes, it is very dynamic and hot area, so further researches are needed to assess the proper candidate to maximize the benefit from such type of potentially tolerable drug. Thank you for your attention.